was admitted with an acute myocardial infarction. 10 days later, he is admitted for an acute anterolateral infarction. Coder, your time begins now, and good luck.
Okay, yeah, this was a little tough one, right? Yeah, but I think it's just breaking them down and really understanding what you're coding for, right? What is this? How do we have all? Okay, there we go. So we have an acute myocardial infarction. So the patient was admitted 10 days ago for an acute myocardial infarction. Then 10 days later, right? They're admitted again for an acute anterolateral infarction. So it turns out we need to code for the current one, right? So let's assume we already build and code for that previous one, but we need to code for the reason for the encounter. The reason for the encounter is the recurring one, right? So let's look at our chart. So if they had a previous infarction and that infarction was 28 days or less, then we're going to sequence it like this. I22 for this one, the recurring one, and then I21. This is what we're going to do. Are you with me? So let's go ahead and document. Patient had an AMI 10 days ago, and the patient's having an acute anterolateral infarction today. Now let's go ahead and look up this acute anterolateral infarction today because this will be the reason for the encounter, right? Because we're going to sequence it first. So let's look up infarction, subsequent, right? It's subsequent. It's an acute one, but it's subsequent, recurring infarction. And then let's go down and look underneath that, right? anterior, anteroapical, anterolateral, anteroseptal, I22.0. This is the first one. So let's go to I22, subsequent ST and STEMI. And let's go down. This is the right category. I22.0, subsequent ST, elevation of anterior wall, and underneath, subsequent anterolateral, transmural, Q wave, infarction, acute. This is first, I22.0. Are you with me? Yeah, somebody's saying, yeah, you should be happy. You knocked it out the park. Yes, you did. Okay, so this is the first one. We're coding for the recurring one first. Next, we got a code for that previous infarction, right? And that previous infarction is still acute because it is less, it's 28 days or less, so it's still acute, and we still use these acute codes. So we're going to go to infarction. What was this infarction? It just says an acute myocardial infarction. So infarction myocardium, if it was 4 weeks or less, I21.9. I like that because there's no mention of the site of the infarction or the type, right? Yeah. So I like it. I22.0 is first, I21.9 is second, and look down here, acute myocardial infarction, not otherwise specified. Acute myocardial infarction. We don't know what type or anything about that previous infarction. And remember, it's I21.9 when the type in the coronary vessel is unknown. So we don't know the location of the infarction on the heart, and we don't know the type. Now, if the type is known and not the vessel, I21.3. All right. Are you all with me? Did that make sense? All right. Yeah, when you just break it down in those digestible nuggets, it is perfect. It's easier when you do that. Outstanding job. Outstanding. I see all kinds of lights going off. I do. Aha, aha, aha. All right, Miss Stephanie, please and thank you.
Coders A 122.8 and 121.09, B 121.11 and 122.0, C 122.0 and D 122.0 and 121.11. 2 days after being admitted for a right coronary acute myocardial infarction, a patient suffers a new anti antio pickle myocardial infarction of the right coronary vessel. The patient is being seen for a new infarction. Your time begins now, and I know you got this.
Aha! All right. I love it. I love it. I love it. Yes, I see all kinds of, comments in here that just say, hey, I got it. I got it. And I love it. All right. So let's go ahead and let's code this out. But first, what am I doing here? I'm eliminating stuff without, come on, let's do this. Da, da, da. There we go. All right, there we go. There's our inventory. This patient was admitted 2 days ago. Well, I guess discharged 2 days ago, right? And they had a right coronary myocardial infarction. And today they have a new anteroapical myocardial infarction. So this is a subsequent infarction, right? And the way you're going to code this subsequent infarction, we're going to use the same guideline. They had a previous AMI, and it's not older than 4 weeks. So we're going to sequence I22 first, followed by I21. And D's the answer. Somebody said, and D's the answer. It is. It is because it's sequenced appropriately. Now let's go ahead and do our due diligence. We're going to look these up, right? And we're not going to look it up from the index because we're given the answers. So if you look at I22.0, this is the code for subsequent anteroapical transmural Q wave infarction. This is correct, right? So I22.0 is correct. And let's look at I21.11. This is the code for ST. This is for the first infarction, the acute right coronary infarction 2 days ago. And it's still current, it's still new. So we still use these acute codes. I21.11 ST STEMI involving the right coronary artery. And that is correct, as opposed to I21.01, because this is coding for another coronary artery vessel. We already know it's the right coronary vessel here, not other. So we're going to get rid of A, and the answer is D. All right. How are you feeling? You are doing this. You're doing it. You should really, really feel good. Someone said, which one is the reason for the encounter, the first or the second? The reason for the encounter will be what is happening now, right now. That documentation for that other infarction, the previous one, is already going to be coded. So we're only dealing in the current, right? So whatever is happening now, that is going to be the reason for the encounter. Great question. Absolutely. Someone said, are we allowed to write more notes in the MCG manual? Yes, absolutely. There are limits for certain, there are limits to what you write, not how much you write. Okay. Great questions, everyone. Okay, we got one more. Miss Stephanie, please and thank you.
Yes, coders A, 150.22 and 150.32. B, I'm sorry, I 50.23 and I 50.33. C, I 50.42. D, I 50.43. Melanie returns to her cardiologist's office for treatment of her chronic combined heart failure. Your time begins now, coders.
Okay, I apologize for that. I'm sorry if you saw the answer. Please try not to see it. All right, so this patient went to the cardiologist's office, and this patient has chronic combined heart failure. So that's pretty much the code, the diagnosis that we're going to code for chronic combined heart failure. And the answer is C. Here is why. Anytime you have a combination code, you use it, right? So when you have chronic combined heart failure, that means you have both systolic and diastolic, and you do not code them separate. All right, so systolic is coded from the I50.2 category, and diastolic is coded from I50.3 category. And combined, they're coded from I50.4 category. All right, so we can get rid of anything that's coded separately. So specifically, if we go to I50.42, this is the code for chronic combined systolic and diastolic congestive heart failure. That's our combo code. And anything from the 0.2, 0.3 category, and 0.43 is incorrect because this is acute on chronic combined. So there's no mention of any acute. So that is incorrect. And your answer is C. And a lot of you got that correct. Outstanding. 100%. All right, so we just have one more topic and then we're ready to go. One more topic, one more scenario, and we are ready. Thank you to my readers. I appreciate you. And now I'll take it from here. This segment of our discussion is cerebral infarction or strokes. And there are a few types of strokes. You have ischemic strokes, often caused by clotting. Hemorrhagic strokes, those are often caused by bleeding, like aneurysms. All right. So those are some of the most common cerebral infarctions. Now, when we code, we have to know the guidelines. Guideline C9D1, sequela of cerebral vascular disease. Well, let me tell you, when a patient has a stroke, sometimes they can have a residual effect. They can have a sequela shortly after. So if they have a stroke, they could have some dysphagia, they could have some hemiparesis, they could have any other type of neurological disorder caused by the stroke, right? And if that happens, you're going to have to sequence first, and the treatment is rendered at the late effect of the stroke. You're going to sequence I69, then you're going to sequence and code for that acute stroke if it's documented. Sometimes it's not. Sometimes they get that stroke, that acute stroke, they get it in, they kind of treat it, and the stroke is no longer, and it's the residual effects that they're just treating, and therefore you don't code it. You only code it if they're both documented. Here's another guideline, important guideline. Guideline C9D1. Sequela codes that specify hemiplegia, hemiparesis, and monoplegia identifies the affected site. So you're going to have to understand what dominant and non-dominant are. Now, dominant means that, hey, this is the patient's dominant side. This is the patient or the side that the person writes with. Non-dominant is the non-dominant side. This is the side of the body that they don't write with, okay? But when it's not documented as dominant or non-dominant, if a patient is ambidextrous, right, the default is the side that is affected. So if a patient's ambidextrous and they have left-sided hemiparesis, if it happens on the left side of their body, then that's the dominant side. If it happens on the right side of the body, that will be the dominant side. So if they are ambidextrous and it's on any side of the body, they're dominant on both sides. So the default will be the side affected. Now, if the left side is affected, remember the default is non-dominant, and the right side affected is dominant. Okay, let me rephrase that. If a patient is, we'll just leave it like this. We'll leave it like this. All right, so let's test our knowledge of the guidelines. I think this is. I just want to reiterate that when a patient is ambidextrous, the default is the side of the body. And that other information that I had documented on the screen, I think it was just left over, from a previous subject. So this is the only thing that we want to discuss. And then we're going to look at the guidelines. Now let's test our guideline knowledge, and we have a scenario. All right. A, I69.351, I63.9, B, I69.353, C, I63.9, I69.351, D, I69.341. After suffering a cerebral infarction, the ambidextrous patient continues to have right-sided hemiplegia that is diagnosed as a late effect. Okay, coders, your time begins now. Okay, let's go ahead and let's highlight our key terms. a patient had cerebral infarction. They are ambidextrous. They have right-sided hemiplegia that is a late effect. All right. So let's go to the guidelines. The guidelines say this: if a patient has sequela of a cerebral vascular disease, C9D1, you're going to sequence first that late effect, followed by that infarction if it's documented. And it turns out our infarction is documented, right? But we're going to sequence I69 first. So we can eliminate C. It's sequencing I63.9. Now, and also just want you to know I63.9 is the code for the acute infarction that's unspecified. Now, we have another guideline that's applicable, right? And I'll show you that in a moment. But if you look at I69.34, this is the code for monoplegia of lower limb. We have right-sided hemiplegia, so this is not applicable. There's no monoplegia. So if we're looking at D, it's coding for I69.34, monoplegia of lower limb following cerebral infarction following right dominant side. This patient is ambidextrous. You got to go. So D has to go. And I69.35, this is hemiplegia. I like this subcategory, right? So let's get rid of D because that's monoplegia, and that leaves us with A and B. We know that A is the correct answer because the guideline told us that we have to sequence the late effect first, followed by the acute cerebral infarction. However, if you look at the guidelines, it says when dominancy is not indicated, if that patient is ambidextrous, then the default is the side that's affected. Also, these two guidelines here that I kind of just skimmed over because I thought it was written in the wrong place, these are applicable too, when not to this scenario, but they're important. So when dominancy is not indicated, if the left side is affected, the default is non-dominant. If the right side is affected, the default is dominant. So whenever they don't say the patient's dominancy, when they don't indicate the hand that the patient writes with, if the infarction occurred and the late effect is on the left side, we'll consider that non-dominant. If it's on the right side, it's dominant. That's if it's not documented. I guess because most people are right-handed, so they just assume that. All right, so the answer is A. And let's go ahead and look at 96351. Hemiplegia and hemiparesis following cerebral infarction affecting right dominant side. We selected the right dominant side as opposed to the right non-dominant side because if the patient's ambidextrous, the default is the side that's affected. So if it's the right side, that will be the dominant side for the ambidextrous person. If it was on the left side, that would be the dominant side. Okay, so it's always going to be dominant if it's not documented. Okay, so answer is A. And if you got that correct, outstanding. Good job, 100% said A. All right, so we're down to the wire. I want to know how you did. How did you do? How'd you do today with cardiovascular? As far as I'm concerned, I knew you would be fantastic. I just did. Somebody said they did awesome. I love it. Somebody said good, good, pretty good. If you missed something, remember, but you learned something. That's better than good, great, or fantastic. That's priceless. All right. Somebody said they started Rocky, but I saw you end. I saw your ending and you nailed it. Yeah, I see my students. I love it. I love it.
Thanks for tuning in, and until next time, happy coding!